Good morning. I'll go right into the presentation. So I'll be talking about surveying the unmet need in pediatric urology and also trying to put together some information about what people are doing out there on pediatric urology, or if it actually exists that people are doing anything in pediatric urologies, as well as the different models that different teams are using for these activities. So today's objectives is to describe the scope of pediatric urology in global health activities and to outline the challenges met by the different teams involved in these activities in low and middle income countries, and to review recommendations made by different groups, whether they're surgeons in low and middle income countries or from high income countries. Just to set the stage, global surgery is just a field of surgery or global health that aims to improve health in health equity for all affected by surgical disease or in persons who require surgical care. And of course, it goes without saying that global pediatric urology would be the same. So this entails multiple international collaborations. And just to expound on low and middle income countries, low income countries are those that have a per capita income of less than $1,050 per person per year. And middle income countries are those with an income of between 1,000 and 4,000 US dollars per person per year. So, I mean, for so many years, people have been doing different activities in global surgery, mostly in general surgery, plastic surgery, but particularly in cleft lip and palate repair, cardiac surgery as well. There's been lots of work in urology, but there's this sudden excitement in the last 3 years because finally in the UN, in the World Health Assembly, following a Lancet Commission report, it was analyzed and felt that bringing equity in surgical care and improving surgical care all over the world was as cost effective as the amount of money spent in prevention of malaria, TB, and HIV combined. So in some other studies, they found that disability rates related to surgical disease, particularly in pediatric surgery, have more attributed in low-income countries in the urologic conditions, particularly in hypospadias or extrophy. It was comparable with high-income countries for conditions such as imperforate anus or having a colostomy. But if it had anything to do with the genitalia, they felt that it was a bigger problem for them socially. So in a country like Uganda, in our clinic, I see patients in a pediatric urology clinic, and over 50% of the patients have either hypospadias, epispadias, DSD, or some other urologic problem. And that's not counting the urology clinic, where they also see pediatric urology patients. From a report made by an NGO called Surgery for Children, an Italian NGO, they made a report to the Global Initiative for Children's Surgery about they do annual outreach visits lasting about 3 weeks in duration in the northern part of Uganda. And most of the patients coming for elective reconstructive surgery, pediatric urologic, so that included hypospadias, epispadias, and some having complications arising from treatment for the same. So prior to current environment of global surgery, like I said, the excitement is in the last 3 years, there have been different types of collaborations. So it's either been church-based missions or faith-based hospitals or institutional collaborations. For example, the UBC and the Uganda Training Alliance, for example, of which I've been a beneficiary. And they've been short missions where either it's part of the institution or a single or a lone surgeon goes out to a place, usually a remote place, and they go and help the population. This, of course, has its own problems, and that's why I come in to kind of set a stage for or build a background to why this might be important to all of us here. So I'll have a few case presentations to help us put this all into perspective. In the first case was an 11-year-old boy who I saw. How I got to know this patient was probably about the age 11. I was asked to put together the story of his medical history and surgical history for a surgical team that was visiting Uganda at that time. What had happened to this boy, he'd been diagnosed with a hypospadias as a child, And before his second birthday, he'd had a hypospadias repair by a surgeon that was visiting from out of the country. He eventually did have multiple, over 7 surgeries to either repair complications arising from this, including fistula repair, dilatations related to the repair of the hypospadias. Eventually, we did see him, and we did bar bodies. At that time, this is all we could do in terms of karyotyping. We're not able to do other genetic staining to be able to determine this. So he had bar bodies, and it was felt that he was a girl. So he also had a cryptorchidism that hadn't been mentioned in his previous charts. When we did a laparotomy on this boy, we found that he had a uterus, bilateral fallopian tubes. He had an ovotestis on one side, which we biopsied, and an ovary on one side. And he'd had multiple complex surgeries where probably someone should have thought, and different surgeons operated on him every year, not communicating to each other, in a hospital that was located in a part of the country that had a civil war at that time. It means no one's going there because of security. The most qualified surgeon there is a general surgeon who does not do any reconstructive pediatric surgery. So if there's need for follow-up or to be dealt with complications, he would wait for the next visiting surgeon to show up the next year. In the next case, gives a different aspect to this global surgical work. Is a 7-year-old boy that I saw who'd had a multiple surgery for cloacal extrophy. He was born in Uganda and had a colostomy placed there. And then he traveled to a neighboring country to a faith-based hospital where he had a closure that fell apart and a second closure. Eventually, he ended up at Sick Kids Hospital, where both the urology and the general surgical teams there operated on him. The short story of this, he ended up with a Mitrofanov and came back to live in Uganda. What happens with this is the bladder extrophy collaboration group or NGO, they send him supplies to Uganda. Some years there's no supplies. This child currently, his status is constantly leaking. His bladder capacity is non-existent. If you scan him, there's nothing in there. He's constantly leaking. He has a colostomy. But what the parents want is for him to be dry and for him to poop through his anus. But there's implications to things like this. So I was asked to assess this child for the need for him to, if he was fit to have another surgery, and if he should travel to see kids again to have this surgery, or to go to Qatar or India for some surgeons that had been contacted. But all these surgeons said that if they operated on him, he would come back to probably be managed under my care. What I told them all from the beginning was I was not ready to look after this because I had no skills. If this patient had any complications, I was not capable of looking after his problems. And so for now, we've left it be, but it's one of those patients like, in Uganda, there's no way you're going to get supplies for some of these things. Like you have a Mitrofanov, where you're getting the catheters for doing catheterizing and things like that. If something complicated from that, who has any skill to deal with the complications following such a surgery? In case 3, it's just a situation that some of you may be familiar with, but in the current atmosphere of immigration, everyone's going everywhere because of something they're not unhappy with wherever they live. And so what's happening with some of these patients? They have pre-existing conditions, they've had prior surgeries, and they come to you with no information on this surgery. In a place like Uganda, I see patients and they have an incision, maybe xiphisternum to pubic symphysis. That's a joke. But a very long incision, and you ask the family, there's no medical chart because it got destroyed in a flood, in a fire or something, or you just got lost. There's no way to keep paper records. And the family tells you something like, oh, I had an operation and I do not know why I was operated on or why the child was operated on. So either they don't know what's happened, you can't figure out what's happened, you could only guess from maybe some of the symptoms the patients might have, but there's language barrier, and so there's all these things to try to figure out, and this brings you cannot escape it because people are moving all over the place and you're going to be affected by the same patients that are going everywhere. In the 4th case, we recently have had some patients who are traveling here from BC, they're traveling to Asia. They feel it's too slow here, the process, to maybe get an image or even something, and they're traveling to get something else done. I mean, it may not have happened, but it's possible that someone could travel and get a procedure done that's out of keeping with your own recommendations or whatever people are currently doing. And then because they live here, you have to deal with that patient, deal with the follow-up, even if someone else has managed them elsewhere. In the fifth case, another child I saw in Uganda, he was a 9-year-old boy living in a refugee camp. He was defiled at age 3 years, and I saw him 6 years later. He'd been having a constant urine incontinence and stool incontinence at that time. When we did a cystoscopy with the team that was visiting then, he had a bladder neck that was open, and it was felt that he should have a bladder neck reconstruction. So this went ahead, and one was done. One thing you have to realize, a lot of these short-term missions happen for short durations. Either it's 1 week, because most people take the time off of their vacations. So you can most employers are not going to give you a month off to go somewhere to do this type of work unless you're on a sabbatical or something. So you take 2 weeks off, 1 week off, 10 days. And so it happens that this child, at the end of this 2-week period, he has the surgery on the last day of this mission. It was a Friday, Easter weekend, and I was kind of fifth assist, the one that passes the gauze to whoever is cutting the sutures and whoever is retracting. So you can imagine how far I was from the actual operation. So there's most times the surgeon who's doing the procedure has come with his fellow and a resident, and maybe one of the local surgeons may be scrubbed in. And I was just, at this time I was a general surgery resident. So what happened with this child? The team leaves 8 hours later. Somehow, probably either his catheter was kinked or something. I was not on site. Someone else was on call. And because I was the only one that seemed to know the patient, I was called to find out what should be done because the catheter wasn't draining. I told them to flush the catheter. This did not happen. So the catheter was taken out, second post-op day. The Foley that was across this bladder neck reconstruction, and they switched it out with another Foley. Of course, following this, he developed severe pain, and he wasn't peeing, abdominal distension. He was extravasating. So I came in to an operating room where we don't have operating lights, no assistant, anesthesia, and nurse anesthetist to redo this procedure or to go and see what's happened. So I was the only person that could, probably because I was the only one who'd been on the table. I have no idea what happened. So I have to go in and deal with this. It was way beyond what I was prepared to do. But this is not the type of case that you do on the last day, 8 hours before you leave.
Where was the team from?
It was a mixed team. So we had a team from Seattle Children's Hospital and a team from Sick Kids. So they worked together in this procedure. But one thing you have to understand with some of these missions, it's sometimes there's the pressure to do good. While the pressure to do good seems like a good idea to do an operation, it's the wrong thing to do. If you've lived with enuresis for 7 years, you could live with it for another 7 years until the right time probably comes for you to do an operation. This is another situation that many of you may be familiar with. It happens a lot in Uganda. A lot of patients travel because they can quickly get kidneys. I mean, go to India, buy a kidney, and you get it. But what's happened is a lot of people will come back. You have to look after them afterwards with infections from bugs you've never seen that exist in a microbiology textbook probably only, and multi-resistant to everything under the sun. And you have to deal with these patients. But patients are under the pressure that they cannot wait, and they want to get it done as soon as possible. So it's not all a bad situation. I mean, look at me, I'm here. And I think the fact that I'm here, I went back home, recognized that the patients I was getting, I was not equipped to deal with, sent a few emails back to UBC, and here I'm back again to get more skills to be able to deal with some of these complex situations. So if at some point in the future I have to deal with some of these things, I think I'm in a better position than I was 3 years ago, but also we're in a better situation than we were because we have urologists, but not many people are doing complex pediatric urology. One of the adult urologists does pediatric urology, but not the complex ones. And so definitely these patients have been waiting forever to have surgery. So in going over some of these, we reviewed some papers to try and put together this information. So we did an online search on a bunch of databases, looked at websites of organizations doing global work in surgery, particularly urology, and looked for those that were involved in pediatric urology. Also contacted some organizations for reports from their missions and what exactly they do. And also we contacted the Global Initiative for Children's Surgery and the American Pediatric Surgical Association for surveys that they had done in low and middle income countries as well as among their surgeons. So there are a lot of terms that we used in this survey, including pediatric urology, pediatric surgery, volunteerism, missions, developing countries, and a bunch of urology conditions. And again, like I said, we contacted these organizations, JICS, APSA, and Kids OR is a British NGO that is equipping operating rooms with pediatric kind of oriented equipment, depending on what the hospital asks for and what they can spare in their budget. So for all the studies that included pediatric urology in their activities, we looked at the complete documents and looked at those, as well as looked at some of the websites to see what information we could get from those and any of the recommendations they've made moving forward. With something like this, most of the information was from the website, and a lot of it is blogs from doctors. And they tell you, oh, I went here, the road was dusty, there was no light, things like that. And there's no real information on, did we do an extrophy? Did it fall apart? And what were the skills of the surgeons there after I left? Could they look after that patient after I went away? That information did not exist anywhere. So I'll do this in parts. So I'll go over the surveys first and then do the online search for the websites and the journals. So from the Global Initiative for Children's Surgery surveyed surgeons in low and middle income countries. And among the questions, so the survey was sent to pediatric surgeons. As you may know, there's very few pediatric urologists in a setup such as that. Most of them reported that the most neglected group were, in terms of patients receiving care, were those with urologic problems, and that included either hypospadias, DSD patients, and those with spina bifida. And also, most of them recommended that local specialist training was the most effective way to go about meeting the pediatric surgical needs. And then in the American Pediatric Surgical Association survey, they surveyed their members, and about 10% response rate. This was about 200 members, and 46 of those that responded were involved in activities in low and middle income countries. 80% of these went into these sites for less than 2 weeks at a time, and only 12%, either the group or themselves, were involved in pediatric urologic activities. Details of the activities were not indicated in the survey. The main challenges here were thought to be lack of specialist training, either it was pediatric surgical, pediatric urology, pediatric anesthesia, and biomedical staff to look after any of the equipment. And again, they feel that there was no local commitment to either training and improving the infrastructure to meet the pediatric surgical needs. And again, over 50% of the respondents could not either host or host in their own institutions an LMIC surgeon to either train them or spend longer than 2 weeks in an LMIC location for either teaching or whatever it is. Like I gave a background to that, most people have that very short duration. And during some of these missions, it's like there's huge numbers and there's a pressure to operate on as many as possible. Very little teaching may happen in such a setup. In looking at the online publications, Using the keywords we included before, over 30,000 publications came up. Most of these were involving activities in cleft lip and palate, orthopedics, and cardiac surgery. But then we eventually narrowed down to 42 publications that were relevant to pediatric urology. And many of these were actually on pediatric surgery. Only 2 seem to quote pediatric urology specifically. Then we looked at about 403 websites of NGOs involved in surgical activities. 51 of these were involved in urology, and 36 of these had activities involving pediatric urology. Then also we got reports from SFC is an NGO from Italy that does both pediatric surgery and urology. They gave us a report of their cases, and over 60% of the patients they saw coming for elective reconstructive surgery were urologic. So most of them were hypospadias, urethral valves, and extrophy patients. Kids OR, like I mentioned before, they give us a report of their activities from the last 3 years. Just to go over some of what people were doing in some of these activities. So Global Initiative for Surgery is a consortium of surgeons from both LMICs and high-income countries that have come together to try and see the best way to go forward in meeting global surgical needs in pediatrics. Because, surgery was lagging behind, but nothing ever in pediatrics apart from cleft lip and cardiac surgery is ever mentioned. So they've come together to try and link all the different groups that are doing, so orthopedics, neurosurgery, anesthesia, and they're trying to get people to commit to some of the statements they're making in the best way of going forward. They're still in lots of meetings and discussions at this point, and they have no document out there that would help guide in the meantime. Mercy Ships is a US Navy ship that docks off the coast of Africa, initially in West Africa and now currently Madagascar. And they get in for a period of maybe 2 to 6 weeks. They will have periods of surgeries done. So they say that they do pediatric urology, but I couldn't find any details of that. Like I said, it's impossible to post pictures of before and after of the perineum. But there is a huge smile picture, so there's a huge lump in the neck or something like that. So it's difficult to say when you have the before and after picture of a huge ameloblastoma or thyroid or a cleft lip. It's instant. But when it's something below the belt, no one wants to look. And of course, there is no way to really post such pictures on such a website. So the details of what they actually do is impossible to tell. But the model they use is they'll go in, they come in with a full-fledged team of surgeons. So people may volunteer, but most of them are from Canada, the US, Europe in terms of anesthesia, nursing, surgeons. They have an ICU in there. So they come and they'll screen the patients themselves. The locals most probably help them to translate to the local language or whatever it is, and then they'll do the surgeries. It's not very clear if they leave the expertise behind when they leave. They say they do some training, but it's difficult to say because in some of these places, they've gone there for years, over 10 years, and there's no one doing these things after 10 years. It tells you something. And then Kids OR, like I said, for the last 3 years, they've been equipping operating rooms. So when we wrote to them, they've equipped 8 operating rooms with pediatric equipment, both in East Africa, in South America, and in India as well, with pediatric-oriented equipment, so to speak. So they'll bring an OR bed, lights. If you ask for instruments, they will bring you small instruments, whatever it is you ask for. They'll bring anesthetic machines and all the tubes. They will service the machines. So they'll come. So if you're interested, they will teach the biomedical people or they'll teach people on the ground how to manage everything, look after the scopes. So what happens with this group is you write an application to them. They have a website and you ask that. You're interested, they'll come and check on your site. And you kind of make a wish list. Of these 8 organizations, they've equipped 2 operating rooms with some urologic equipment, but only one of them asked for urologic equipment. It tells you something. Like, even the local surgeons may not think that urology is a priority, but it's the majority of the patients that we do see in our clinics that require urologic care. A lot of the reconstructive problems in pediatric urology probably would not kill you, but it's a huge problem socially, and So a lot of people don't feel that there's a need because it's not going to kill you in 48 hours. We don't need to act on it. So some of the other NGOs, IVUMed is International Volunteers in Urology, is out of Salt Lake City, and they've been doing urology for decades. In some of the places they've gone, they've created collaborations. For example, in Senegal, they've created a training program where people could go and train in urology. But in some of the places they've gone, the relationship has fizzled out. And it depends on where the relationship, what are the objectives going in? It varies, and in a place like Uganda, they came, but for the last 3 or 5 years, they've not been back. Maybe the relationship has died. And after all these years, we don't have a pediatric urologist or anyone interested in that from the urologic team that's been managing. Urolink is the British Association of Urology kind of global surgical arm, and they built or have helped establish an institution in Tanzania that trains urology. So you could get, if you're a general surgeon, you could get an MSc in urology from this center. They do lots of urology, but again, they do a lot of pediatric urology work. But what's happening with most of the surgeons when they go back home, they will do only adult urology. Most of the ones that have trained from here that come back to Uganda, none of them is doing pediatric urology at all. Then there's a bunch of others who work with different models. For example, the Association for Bladder Extrophy Community. This group will, for example, they contact surgeons in a place like Uganda, for example. You identify the patient, and they'll fly the patient out to India or wherever they feel that there is an extrophy surgeon. But at the end of the day, what that results in is we have lots of patients with bladder extrophy. And at the end of it all, there's no expertise because all the patients, you're flying them off somewhere. And there's implications for something like that. Then Emergency is an NGO that initially dealt with war surgery in Afghanistan, but now it's moving into pediatric surgery. It initially started with cardiac surgery in Khartoum, but now they're trying to move into different surgical specialties. But the model with which they work is, it's an Italian NGO. They come with all the personnel, the physicians. They do not employ any of the local physicians. They may employ some nurses locally, and they want the local surgeons to refer patients that require elective pediatric surgery, whether it's urology, neurosurgical, cardiac, general pediatric surgery, to them. So at the end of the day, they say that they have the hospital built and manage it for about 10 years, then they hand it over to the country. But what happens with a model like this is when they leave in 10 years' time, there's this huge white elephant with all the instruments you need in the world, but no surgeon that's capable of using them. Cure International is a faith-based hospital that does work for patients with disabilities, orthopedics, but includes spina bifida. They also do urology. What they've done is they have hospitals and they have surgeons, both local and international, that are stationed permanently in these locations. Some of them have training programs for general surgeons. So some of them do get some skills in pediatric urology, and some may go ahead to do them, although it's not indicated how much of pediatric urology that they do. And the list goes on with different organizations. But at the end of it all, in summary, what we were able to find, there's not very much there in publications of what people are doing. So most of the information we did get was from those surveys that were done of these surgeons. The most neglected group was complex urologic patients that were cloaca, bladder extrophy, and DSD patients, as well as those with spina bifida. The websites, like I said, had very little information on what exactly is going on with the challenges. It's more of like, as Dr. McNeil say, climb Kilimanjaro, there's a few gorillas here and there. But, which is not, I mean, while you're there, you might as well see the gorillas. But what I'm saying is we need more details on what it is you did, what the challenges are. Maybe you could give a tip to someone else who's doing a similar activity in a different location. And so from the publications, the challenges echoed those from the same websites, and the recommendations remain the same. That training was the most important thing, but the biggest question remains: how do you train a surgeon for the LMIC country, or how do you train a surgeon that's going to work there? And there's a huge fear that there will be brain drain if you brought a surgeon such as myself to a place like this, that everyone's scared that I'll not go back home, and or if I went back home, I'll not be able to work over there for one reason or another, saying something like, "Oh, I do not have the Castro. Give me the 7-0 Vicryl." Throw instruments here and there because you don't have exactly what you want. But one of the things that we've shown with the UBC, Uganda Training Alliance, is it's possible to go back, adapt some of your learning to the situation, and be able to deliver services. I mean, I'm coming from pediatric surgery, but it's still possible that urology can teach a pediatric surgeon how to do pediatric urology and still meet the needs of a population such as this one, where everyone's a baby. Yeah. So in one of the teams, some of the recommendations they made is, if the collaboration is stagnant, it's not going forward, everything's fizzled, the activity is not kind of growing or generating more surgeons, it was thought that maybe they should switch to either a different center or a different team. So for example, if, IVU Med has been working with a urologist in Uganda, just for example, would it be wise for them to switch to working with the pediatric surgeons in the country to try and get this forward? But the question is, what are the durations of this training with some of these groups? IVU Med goes for 2-week or 1-week durations. They do a bunch of workshops, and if you're at a certain level of training, 1 week adds a lot to your skill. If you're at a certain level of training, it just gives you more problems. It gives you ideas that you could do something, but you could just kill the patient or destroy them by whatever intervention you might do. Again, there is no easy way to measure what these trainings have been able to achieve in some of these places. So people say that we're doing training in the 2-week durations, or for the 10 years we've been going for 1 week at a time, but there's no information out there to say that, can we measure the skill? How are the patients looked after we've long gone, or something like that? So how is the service being provided in those places? So in our conclusions, there's a lot of work being done in global surgery. Pediatric surgery does lag behind, and there's very little even written about pediatric urology. There's a great need, as identified by both surgeons in the LMICs and those in high-income countries. Most global missions are short-duration missions, but they're not the best model to transfer skills unless they are helping to get rid of huge backlogs. More information is definitely needed to specify urologic needs in regards to the pediatric populations and develop a way to move forward. So we've been thinking about this. So this is just a background of some work we're trying to get into. And trying to go forward, we'd like to probably design another survey that would go to surgeons and other like-minded stakeholders to find out the direction people are going with, or what they're involved with in pediatric urology. The specific things that we're not able to find is things like the confidence level, or how skilled are the surgeons in the places you go to. Is this place the most skilled clinician there, a physician's assistant? Should you be doing a hypospadias repair or a bladder extrophy repair in such a location? Is the most skilled person there a general surgeon? Again, are you going to do a spiromonty in that location? If things go south, is that person able to deal with the complication that may arise from this problem? So our hope is that going forward, after we get all this information, is to develop a document in consultation with a bunch of other people in ways to go forward in how to help improve pediatric urology for the greater global community. Thank you.